It's my pleasure to invite Peggy John, Associate Director, Organ and Tissue Donation and Transplantation at Canadian Blood Services, to present our next speakers. CBS is proudly supporting our session evaluating CDTRP's patient, family, and donor impact. Prior to her role at CBS, Peggy Jones successfully established the Live Life Pass It On brand at BC Transplant and collaborated with Service BC and ICBC to provide registration opportunities and organize Canada's first national organ donor registration drive with Global TV. As the leader of Canadian Blood Services, Education and Awareness team, Peggy is dedicated to fostering a culture where organ donation is the norm in Canada. Thanks, Peggy.
Thank you, Vanessa, and good afternoon, everyone. It's truly my pleasure to be here. I know that I speak on behalf of our whole team when I say that we are honored to work in this space, and we're very pleased to be able to support today's session. And so I'm going to keep us moving along really quickly, and I'm going to invite a few people to join me on stage. Audrey L'Espérance, Manuel Escoto, Sandra Holdsworth, and Fan Bei. If you could please join me on stage. And I'm just going to introduce Audrey to get us started. If I could, Audrey is Assistant Professor at École Nationale d'Administration Publique in Montreal, specializing in health and social service management. Her research centers around patient and public partnership in the health ecosystem and the integration of experiential knowledge in policymaking processes. And I'm going to turn it over to you, Audrey.
Gonna come right here. Hi. That's great. Sylvain is doing the mic moves. Thank you very much for having us, and thank you for my fellow panelists for today. I'm Audrey L'Espérance. I've been with CDTRP almost every year since Quebec City, and I've been always being the plus one of Sylvain sometimes. So I'm really happy to be here with you, and it's always a pleasure to support patient engagement wherever I go, and been doing it for the Center of Excellence on Partnership with Patients in the Public for 7 years, and now I'm doing it as an assistant professor, and it's a very big pleasure. Last year I joined most of you in Kelowna for a session. I was more I'd say conversation oriented, because we and a bunch of my colleagues and I co-constructed during the pandemic, during the intense phase of the pandemic, I'm just gonna go here, an evaluation framework to evaluate patient engagement in research, and by co-building that framework, we wanted to also use the framework in some of the organizations I've been involved in, CDTRP being one of the research networks that I've supported for a few years, but also other types of research networks and healthcare organization, and help them actually situate what they were doing with patients, what partnership was about, what patient engagement was also about. And so we moved on from theory to practice and tried to use the framework in an organization. And that's what we did with the fellow, the folks you see up front. We created this committee, and after Kelowna last year, where I presented the framework and had a conversation with a bunch of you actually, who told us what was important for CDTRP to evaluate, what was considered as good indicators for patient engagement evaluation, what actually was meaningful for patients and researchers at the CDTRP. And we collected that information, and when we went into a meeting with Manuel and Sandra and tried to move from, again, theory and try to build your own CDTRP framework and adapt this this framework to your needs as a research network. And that's what we did. We actually decided to do it 3 ways. The first aim was to learn from what was done in the past 10 years of patient engagement at CDTRP. And that's great because we had data. Marie-Chantal and Sylvain and I and Fabienne, we all collected data. I don't know if some of you remember that we used the Picori questionnaire back in the days and asked you what your intentions, your expectations of patient engagement were. And we also continued this work, and I'm happy to collaborate now with Davina Banner-Lucaris, who's at UNBC, who you probably maybe met because they've done a bunch of interviews with some of you in the past years to collect data on what was going on and what is going on at the CDTRP. And through that collection, we were able to kind of come with some learnings about the 10 past years. But going past is one way of evaluating. We like to think about evaluation as a way to look further. So that's what we actually did as a committee and tried to figure out what can we do to follow more closely what is patient engagement at the CDTRP and eventually improve what is already done. And so we wanted to build a framework that was really specific to the network and also build capacity to actually collect and keep track. So here we are. We've done a bunch of adaptation. That's what we did for the past year. And now we're actually where we made choices and we want to share these choices with you, but have a conversation also about it with you, because we made choice as a group, but you might not agree, or you might want to add some things or change a few things. So, but we ended up, and that's Sandra's doing actually. Sandra came to a meeting one day and she's like, yeah, there are a bunch of indicators in there that are great to tell a story, but there are also a lot of them that are there to reflect for the future. So almost like if we had a dashboard, those metrics we need to understand what we are doing. Sometimes it's the numbers I've seen in the slides prior to this, numbers of patient partners, who is involved in what project. All these things can actually be collected. And those can actually be almost reported back live. It doesn't need to be, just a once in a year type of thing. You could actually do it, on an ongoing basis on a dashboard. So we actually listed the dashboard priorities. So those indicators that we could put on a dashboard and follow through the years. And then we also identify a bunch of reflection indicators. So all these elements that are not necessarily already collected, that means a bit more about reflecting on what's going on, what we want to improve, what we want to actually build for the next phase of the network. And those are sustainability indicators to a certain degree. And so I'm going to go back. So we listed a few of them. Just going to go really quickly around what they are, because we made choices. The framework we built at this with my team is an elephant. And what I said from one of the first meetings we had, it's like, we're not eating the whole elephants, guys. We're just going to eat the parts that make sense for CDTRP. So we made choices, and we made those choices together. The first one is the diverse perspectives. You want to recruit patients that have diverse types of experiences. I'm not saying and talking about sociodemographic profiles. I'm talking about experiences like caregivers, family members, donors, or even, transplant recipients. You might want to actually diversify that community as well. So yes, profiles, but also, the experiences themselves. Also align them with the projects. You might have projects that ask for different types of patient partners, and that's an important piece also of diverse perspective. The second one is the partnership guidelines. You have a bunch of rules or ways of doing things. I'm thinking about compensation standards or terms of references, things like that. You need to keep them going, keep them living. They are living documents. So these are important things to follow and to make sure that they are still up to date. Project co-design. So are we co-designing projects? Are we setting priorities with patients? Are we still doing that? And then communication. How are communication going? How is the information flowing in from patient partners to the network, but also from the network to patient partners? How are we supporting? And supporting is not just give something, it's also lifting barriers. So how are we doing that on a day-to-day basis? And the last one is building capacity. A lot of questions, and that's something that Key was really informative about. It was that idea of supporting the readiness for engagement, but not just from the get-go, but ongoing support and capacity building for trainees, for researchers, but also for patient partners if they need to. Good. We'll talk about those a little later. Don't worry. You'll have a word to say on this. And then we identify a bunch of reflection priorities. The first is that idea of readiness. So there's training and capacity building, but then how are we creating that ongoing loop of creating readiness within? How can we refine our engagement or partnership? How are we actively involved in improving patient partnership across projects, but also in the network? There's this whole bunch of indicators on inclusivity, and I'm really happy to hear. I've heard Lori talk about that desire for inclusivity at the CDTRP at the time, and I think that's a very important, I'd say, value that you're carrying, and I think that patient engagement also needs to carry on. Transforming practices, it's about like, what are you changing? And that's something that actually Sylvain spoke about. Are we changing something? Is there something, changing because we are partnering with patients? And it might not be, we're changing the world because we had a bunch of patients in the network, but there might be a few changes in practices and how we do research that we need to keep track of. And finally, is the research relevant to patients? And I think that's also a driver that drove most of the researchers in the room for a long time, and it's still something that we can check every year to be able to say that it is or it isn't, and we need to make changes. Before we move to the I'd say discussion part, I wanted Sandra and Manuel to talk about how those two bulks of indicator, what they mean for them. Because I've been around, but I'm not a part of the network, so I can talk about an evaluation of patient engagement for a long time, but it's not about what you as a collective live in. I think that they saw, a specific need for these choices within your collective. So maybe Sandra first, because you had that idea of separating those two sets and thinking about that.
Yeah. Sad thing is I can't remember that, but that's okay. I do.
Good.
I sometimes just come up with ideas and people grab them, which is what works good. No, I think it's important to sort of like, a lot of the things that were on the first part are things that we have that are measurable. And we set up in place so that we were in a good position to engage with patient families and donors in the work that CDTRP is doing. But as we go forward, we need to look into like, what are some of the things that we could be doing better, and then how to reflect on where we'd be going in the future. How can we one of the things I think about is mentoring others into leadership roles and things like that. Yeah.
Yeah, and I remember one thing that you told me was that there was tons of things done, but it wasn't of knowledge for all of. It wasn't enough knowledge for all of the community at CDTRP, that you wanted to spread.
What's happening?
I'm not all the things that you were involved in, it wasn't necessarily known by all of the members of CDTRP.
Yeah, well, yeah, I've been around for a long time, and I came through the CDTRP for my work on Can Restore with Sunita and Tanya, and Tom was at this Tom, I'll call him Tom BH by the names. He was there and he was telling us about CDTRP starting up and that. So, and then, you know, I met people like through David Artell and Helen Campbell and stuff. But yeah, like there's silos of group that were doing things and researchers that were reaching out, but not everyone was working together. I don't know why it's doing that. Are we over already?
Out of time.
We're not out of time, but we still have 64 minutes and 8 seconds. Thank you for that. Manuel, maybe you can actually transfer what you think is useful in this and how, you know, what it means in your work.
Yeah, sure. Happy to talk about it. Just want to start off by saying thank you to everyone for joining, of course, today. For those who don't know me, Manuel Escoto, and I'm the Patient Family Donor Partnerships and Knowledge Mobilization Manager with CDTRP. Been in this role for about over 2.5, going on 3 years. Time flies. And very, very, very honored and privileged to be in this and have these part of the discussions with everybody in this room. Part of what we're talking about here, you know, it implicates everybody, researchers, of course, our patient family donor partners and our trainees. And I see we have several ones here. So as we get, I will say my early plea, as we get into the interactive session, please share your thoughts. As we build this dashboard, it's really imperative that we have everybody's thoughts and perspectives included in here. With that, I mean, in terms of the dashboard priorities, you know, one of the things that I've noticed over my, let's say, going on 3 years here is, as you mentioned, Audrey, there seems to be a disconnect between what we do at CDTRP with respect to our patient partnership platform and what people know about it. I think there's a lot of great work, and I might be biased in my role with saying that, but there's a lot of great work that's happening at CDTRP and the way that we integrate our patient partners, our patient family donor partners within our various streams of work. I mean, Patricia talked about it earlier within our, you know, our PFD partners are leaders in our themes and our hubs. Because of then we've changed how we do our innovation grants. The feedback that they've provided us really makes a difference in what we do. So all to say is there's a lot that's happening, and our patient partners really are leading the way in how we keep making things better. So the disconnect is there's all this great work. How do we get it out there? So in establishing the dashboard priorities, it's really a way of us, and we probably should have done this several years ago, but it's really a way of us getting that baseline. You know, where are we now currently as a network that we're trying, and as we continue trying to improve, where are we? How can we collect? You know, some of it is some I don't know if basic's the right word, but some basic data of how of who's part of the network, how they're making an impact. I think that's something we should be proud of. And I think everybody here should be really proud of how we are integrating our patient partners, because we all have a certain role in this. So we have this dashboard. I'm not going to pretend that we are perfect, and we are continually learning. Myself in this role, I'm continually learning, and I'm very grateful, Audrey, for your guidance and support as we've been developing this dashboard. But when I look at the reflective pieces of the priorities, it's really, where do we want to be? You know, we've talked a lot, and I think we're going to get a little bit more into this next session or later on in one of the days. But, you know, when I think of CDTRP as a network, you know, we're undergoing a stage of transition. And how can we integrate our patient partnership platform into this transition period where we're going? How can we improve? You know, what do we want to improve as a network? What do you, everybody here, want to improve on as researchers, as patient partners, as trainees? I think that's the important piece for the priorities is what can we do better? I think we're doing a lot of good, but I think there's still some work to be done. And thank you to our patient family donor partners for holding us accountable in those things, because that's what's really going to make us see where we want to be. So again, this working group that you see here, we've decided on these pieces, but as we get into the interactive stage, you know, does this resonate with you? You know, are there pieces here that are missing? Of these pieces, what's more important? You know, where would you prioritize certain things? So maybe I'll pause pause there. And we can move on to the next little piece.
Go ahead,
Yeah.
Sandra.
So I just wanted to, sorry, I was thrown off there for a little bit. I apologize, but I just wanted to say that one of the things that from all the patient partner work that I did, I really think that CDTRP, when we first had like that meeting in 2015, when we brought everyone together, and then as we led into like, you know, bringing on like Sylvain and having the PFD platform and people doing the research and you know, the research that was done with my friend Heather Talbot, who's a donor mom. I think that was just like amazing work. And I think it was something that you don't usually see in this field. And so I do want to say, give credit, because when I originally talked about doing like an abstract, I wanted to focus on some of the successes that of the partnerships that I've had with researchers and teams and that other patient partners have had. And, you know, and it's out there for sure. And, you know, when it works well and when people do it, then they realize it and then they'll want to do it. But we also appreciate that, you know, it takes more time and that we also appreciate in healthcare and in research, we're always talking about people working off the side of their desk or, you know, trying to do two jobs. You know, it might be a clinician and a researcher as well. And, you know, and the funding and everything like that. So we get that. But I've worked with some amazing teams and I think CDTRP should definitely be proud of what we've accomplished with our platform.
Thanks for those. Well, okay, perfect. Yeah, no, thanks for those comments, Sandra. You know, you said something interesting there about, you know, working off the side of our desk, and I think that all resonates with everybody here. You know, we're all busy folks. We all have limited bandwidth, but specific to PFD partnerships, you know, I should have said earlier, I'm also a kidney transplant recipient. So like, this is something that is one very, very meaningful for me. So very privileged to be in this role. But something like patient partnership should not be off the side of our desk. And, you know, when I think of where we're going as a network, like I would be darn proud if everybody involved in donation and transplantation research came to us for guidance, for active support on how we can implement some of these pieces with respect to patient partnerships. I get it. It's probably not feasible for every, you know, single researcher trainee here to do that work, but that's why CDTRP exists. And as we continue getting better at this work, I would say that's one of my long-term goals. So when I look at these reflection priorities, that's really what I'm aiming at as a manager in this role. And I think in the direction that we want the network to go to is really be that go-to platform where folks perhaps don't have to call it worry about these things as for lack of a better word, but that's because we're here. You know, the platform is here to support them individually. Yeah.
Kia, I want to give you the opportunity to present yourself, introduce yourself, because we didn't. But also, I'm going to ask you directly, like, what does evaluation of patient engagement mean for a trainee? Because like that's the perspective you brought, and it's also like an interest of yours because you came in a bit after the rest of us started to meet, but with a very interesting abstract about like the need for evaluation. So I was just wondering, and maybe introduce yourself at the same time.
Thank you.
Sorry.
Hi, everyone. Thanks for being here. As I've been introduced, I'm both actually a trainee as well as a PFD partner. Is anyone coming out? With CDTRP, and I joined CDTRP at the beginning of my PhD, and now I'm actually in my 4th year. I've been a recipient for about 10 years now in terms of transplant, and so I kind of wore both hats. And this is what led me to be interested in this. It's like, I see these two pieces and I see CDTRP being put in an effort trying to bridge those two, as well as like researchers. But often the case, as well as in academia, these 3 pieces are very separate and siloed. We're each focusing on research, on health conditions, and we rarely have interactions. So with such a great platform, such a great opportunity as this network to be all here in this room with different and various backgrounds, expertise, as well as lived experience, how do we engage? How do we take this opportunity and have fruitful conversations? So one of the pieces that was talked about was readiness. And that's, I think, one of the pieces that I wanted to touch base on in more depth, because we are all very comfortable in our own comfort zones and what we know. How do we articulate our experience and what we want to the greater audience? And that's like one of the reflection priorities that really like intrigues me. How can we utilize different resources both CDTRP currently offers, and we can develop more resources that CDTRP will offer so that we can become a more collaborative environment. And so, yeah, Manuel and Sandra has touched on a lot of key points. And that's kind of what I want to touch base on. It's like, since we're so close to Christmas, I like to use the analogy of Christmas, past, present, and future. Where are we going?
There you go.
Thank you. Thanks for that. Because like, that's exactly what we want to do, is to make sure that even if it's not in this actual structure, that patient engagement is an ongoing component of research. And that's a way of sustaining also the work that's been done into an extension in labs or in, research projects and collaborations that you've built through CDTRP. I want to move on to specific questions, and it's questions that we will open up to all of you. So if you want to prepare yourself and maybe write your ideas on paper, because you'll have an opportunity to come to the mic a little later, and also use the Mentimeter, which will also be provided to you. So if you have your phone around, just take it on, because like the QR code is going to be on the screen, and you'll be able to actually answer all of our questions through your phone as well, if you don't want to come directly to the mic. And for people online, actually, it's going to be easier also to participate if you use the Menti. So we wanted to ask, broader questions. We set this stage and the ideas here, but we want to know, basically two sets of questions. One about like the story. We created those two lists, the more dashboard type metrics, like the story, what are the activities that are done in partnership right now, and the other set that are like the reflective ones about the future, what we want to improve. And our questions are around these two, sets of questions as well. So first question we wanted to ask, and I'm gonna, go around and ask those questions directed to Sandra, Manuel, and Key, because I think they have something to share with you, but it's also going to be a way to start this conversation. And the first one is, what do you want to know about CDTRP's PFD PFD partnership platform that you don't know? You might know a bit, but there might be things you don't know. Or what do you know that you want to share with others? That would be the first question. I'm going to go around and start with Sandra. What do you want to know, or that you want to share?
Oh, well, I think I already did that.
Yeah.
I can answer the last one if that's okay.
Yeah, for
Or you
sure.
can-
How do you present results back to CDTRP members?
Yeah, because I've already shared what I felt about CDTRP, and I think it's something that we should be shouting from the rooftops, right? One of the things that you talk about, I've learned about it being part of the organ and tissue and donation field, is we tend to talk among ourselves, other than when we're trying to get out there and raise awareness, right? So, but a lot of time we find ourselves sharing that message in rooms with people that already want to be a registered donor or, are connected. And I remember doing the talk, I guess it's been over 10 years ago, and I said within 10 years, you're going to either know a transplant recipient like me, someone who's waiting, someone's a donor, or someone's a living donor. I think probably all of us can say that, well, definitely in this room. But I think that one of the things that we need to do, like we have some, amazing website. We've had some, anyone who goes on YouTube and looks at all the different webinars that have been put together. I mean, you could spend like hours going back and seeing some amazing presentations in that. But I really think that like we need to somehow get the word out. Like if we get a newsletter that goes into like to the hospitals, or we have like something that goes into a community center or something, because like one of the things about research, we talk about research like patient-oriented research, and you know, and also you know, we talk about like my first in meeting of Vincent Dumais, when he's talking about the patient revolution, and he was talking about, you know, patients being at the table. But I think now, like, I think that patients are like, I don't know about here, but in Ontario, we're sort of getting to the point like, and Sylvain mentioned it as well, like some of the things that we've been talking about, like, you know, the work that I did with the organ and tissue donation collaboration, I'm like, I remember doing this 20 years ago. We're still talking about the same thing. I could actually pulled out the report and I said, here's the recommendations. Wasn't there a report done for like, you know, in 2011 of the recommendations that need to be done? So I think that somehow we need to like, you know, get that information out to the public. And what I was going to say, I think that patients, families, caregivers, and then our situation, donors, we want to be the ones that make the decision about our health. I'm getting sick of being like using a system that was not created for me. And so I think what we're going to have to do is somehow get community more involved, get more people on board. And, you know, even the way that our research is shared, like I'm on papers that I can't even get access to. And so we need to find ways that we can share the information with the public. And I think that's something that would make a good way of getting the information out. I think we do a great job internally, but I think it's in the community. I think we'll learn a little bit about that when we hear from the media group.
Thank you, Sandra. So you saw the QR code. We can put it back if you need to, or did you have the time to kind of scan it? Did you?
You could also go to menti.com,
Yeah.
put the code up there.
Exactly. If
miss
you
the
go to
QR code.
menti.com, you can use the code directly or scan the QR code with your phone. Or if you like the old way, come to the mic.
Yes.
That's also a way, because while you're preparing and thinking, I'm just gonna go and ask Key what you would want, what activities, what things would you want to put in such a dashboard, and how do you what would you want to make it diffused and known about?
In terms of dashboard, I'm gonna set that slightly aside. Well, I want to address the first question
Yeah.
about what I want to know about CDTRP. And I want to say all of you guys, like that's why we are here. I want to like communicate and have conversations and have coffee talks with everyone and see everyone's perspective. And what I want to share is that as a trainee with colleague with Francis, that we also have late summary and as well as other activities for trainees. And back to the dashboard, that was kind of an aside. So what are things that are missing? Well, we have quite a lot right there. And I think we need to find a few focus points to focus on so that we have something that is structured and that we can build upon. And something that's for everyone, for both the PFDs, for both the researchers, as well as the trainees. So we're not all in our own little bubbles, in our own little labs, as well as in our own little research and research topics, so that we can come to collaborate and share understanding and our thoughts. Yeah, and then what can we bring back to the members and in the external environment? As Sandra did talk about, I find the academic environment kind of interesting. We're paying to publish research, and we're also paying to access those same research. And those research, given how much we have to, how much barriers there are towards accessing them, how we have to access through like academic institutions, they're not open and readily available for both PFDs as well as early career trainees who may not be part of like larger institutions. And so is there a way that we can share more of the research that's coming out of CDTRP and CDTRP partnerships? And how can we turn those research into understandable information that is more publicly available, such as public communication. So it's not just locked up into like so-called the ivory tower that's only accessible by researchers and people who understand the jargon, because jargon is not accessible and it's very old for a certain group of target audience. And that's not what our goal here is. Yeah, that's my thought.
Thanks. I'm just hearing there's so much about, diffusing what's been done, inside, so within members of the CDTRP, but also outside, and that's what I'm hearing from Sandra, but also, keeping more track of what's going on. I'm gonna go to Manuel because we had a discussion, and Manuel, I gave him a homework the other day. Sorry about that. I said, Manuel, there's this list, but I want to know what you already track, because there are things that are tracked. What are those, and what needs to be tracked better?
Yeah, no, if we can go back to my laptop died, so I can't pull up my list here, unfortunately, but yeah, I guess in terms of like what do we want to share? We've mentioned this, right? I've kind of mentioned it, and Patricia mentioned it earlier. Our PFDs are involved, I would say, in all aspects of our network, from governance to projects to the way projects are changed, or to the way we kind of refine our processes when it comes to PFD engagement. So in terms of what we want to share, it would just be that. And we do collect metrics on that. Like, we know what we have to do better is how to systematically collect them better, but like, we know, or we can collect, for example, how many of our PFDs are now co-applicants on grants, which I think is huge. And that's something that we've really taken a step over the last year or so, thanks to the work of this great, fantastic management team here. I don't see Katie here, but I was going to give shout outs to Katie because she really helped us. With that. Our PFDs are taking active leadership roles in projects, CDTRP led projects, but also research member projects. You'll hear about one of them tomorrow, I believe, through the Treat COVID work. So there's metrics like that I don't think people are really aware of what's happening, but we can certainly provide these nice, beautiful numbers of where they're making impact. In terms of like who should be told and who needs to be told, I mean, it's going to be a boring answer, but everybody. Sandra actually really hit on some of the points I want to raise. What I have found in my, again, call it almost 3 years here, is that we need, as us as a network, but also our partner organizations, we really have to leverage our collective work and expertise better. I worry that sometimes there might be too much duplication of certain work, and ultimately that's a loss of resources. That's a loss of time from staff and patient partners. I think there needs to be a better way for us to communicate the work that's happening, and that kind of leads to what's activities or issues are missing from the list. I can't comment on that because I helped come up with the list, but I think one of the things I will use this time to address is a need to have better presence, call it, better ways to communicate specifically with whether it's clinics or transplant centers. I mean, that's where patients are. And if we're looking to really diversify the voice that CDTRP has, I think that's one of the key places that we really have to hit. Now, how that's going to happen, I'm not entirely sure yet. So would love people's thoughts on that. But, there's different ways when I say diversify. It could be patient PFD profile. We have a lot of caregivers, but is that a sufficient representation of folks in our network? We could probably use more. One of the things I sometimes feel sheepish in, I suppose, is when I'm looking to, when I'm supporting a PI or a project team to find a suitable number of patient partners, and I'm unable to fulfill that request. Not that I'm not able to, but so I'll give you an example without giving any names. I'm currently searching for 30 patient partners who are going to be, well, not patient partners, but research participants in a specific study, and we don't have that profile within our network. So I'm working with partner organizations to try to leverage our partnerships in that, but something like that, like I said earlier, I want CDTRP to be the go-to platform, right? So my goal is to build that, and I think part of that is that EDI perspective, where we have to diversify who's at the table and how can we encourage others to be at the table. Yeah, I'll pause there.
It's interesting. I put my mask back because I want to go around if some of you want to speak to that conversation. But I'm just looking at the answers as well to the questions, and I see almost 3 types of answers. One is about what's done elsewhere that we can kind of learn from. So good practices, best practices, but also experiences from other networks. I see also elements that are about, what it changed within the project. So there's probably information missing about, what are the things that really was impacted, if it's people or research, but also then everything more structural. How can we better help and support and better integrate patient partners into the research? So I'm just like wondering if there's someone. I'm coming back to you, Sylvain. Yeah.
Thank you. So I wrote some of the things. I don't know. I think I have maybe a comment or things that people have been asking me for some time now, because I've been working with patients for now since, I don't know, in the last 10 years, I guess. But one thing is, how do we define engagement success? So I did some work with the student at the School of Physical Therapy, and we asked patients and we asked professionals, researchers. I think they might have different definitions. So I think a clear definition of engagement success would be great to have. So I think this is one thing that might be missing, or maybe you have it and I don't know, because I think it will lead this to investigate a little bit of impact. So are we being successful? Because I think when I read research in patient partnership, patient research partnership, it's most of them are all about the satisfaction or the interaction. Is the interaction working? I think now we have enough to know that the interaction is working, or may not work because of this, and you can improve. But now, what is the importance of having this partnership? What is the impact? So if you think about long-term goal, we want to have we want to have the opinion of patients to have a meaningful project to impact on patient outcomes. At the end of the story, I know this is really hard to evaluate, but can we collect some kind of information from the studies that would, give us an indication of impact? How are we impacting research and health in patients' lives with this partnership? I don't know the answer, but I think this would be interesting to know. Maybe
Yeah, that's a great point. And you know what actually pushed us to co-design that evaluation framework from the get-go? 2 things. Researchers asking us, what is it changing? What's the impact? And patient partners asking us, what's the impact? Okay, so in both ways, the reciprocity is there. So both want to know what they are transforming, because they are in it for transformation purposes. To get there, and that's one thing, we need to track our activities, and we need to keep, an understanding of what is happening. And that's actually where I think most of us are now. It's like we want to rigorously structure the way we, keep track of successes and failures, or, improvements, to be able at one point to say specifically what we impacted collectively.
I remember we said readiness, and I was always saying willingness. And in all the experiences, not only at CDTRP, heart failure, arrhythmia, sleeping, so many projects. If the willingness is not there, I don't have anything project at work coming out of my mind. So I think for me, willingness should be not measured, but I don't know, but the willingness needs to be there. being forced to have a patient partner in a research to get the money, I've seen catastrophe that cost probably millions of dollars, and I always said that j'ai toujours mal à mon contribuable. So the taxpayer of me is saying like, I know they took the patient, but they never called it. Okay, so this is one thing, and also I think also using the patient, it might be later, knowledge transfer. Okay, knowledge transfer. I know the classic. We will publish. And then we will talk to our society. Guys, you've been saying that for all the projects. And I've been saying that a couple of times. You're boring about that.
Yeah.
Think out of the box. Sunny, with Heather, probably you wouldn't have done that without Heather. And I remember seeing you saying and being published in Globe and Mail and things about that because he did it with Heather. Laurent, Projet Laurent. It's not only Melanie and all the others using patients to collaboration. That is different. That is different for all the people and saying like, oh, that's great.
No, I like that point, and I want to make a point about that because, you know, some of you did, you know, collect or talk and actually I was seeing in one of the answers, you know, gathering stories about, you know, what happened or partnership. But we have stories, I think about Sony, but it takes you out of your research field for a little while to do that evaluation work about patient engagement. I have the big, you know, it's a privilege for me to be able to do 100% of my work on patient engagement. If you do that, you take a part of your time that is always scarce to do that work. So that's where the network can actually help you. And I was just seeing your, if you want.
Yeah, I think you're on the right track. What I've always struggled with is that CDTRP has been an innovator right from the start. Mary Chantal, Sylvain, Fabian, you know, started this thing, started preparing it right from the very beginning. So here we are. I'm still wondering, are there people who do it better than us? Or are people follow? Everyone's doing it. CIHR followed us. Every research institute is following us. Critical Care Trials Group. They're all doing great things now. Are we still leading? And if we're not, let's not fall back. But what's the next step for us? Who are we going to follow? And if we're not following anybody, like, let's take a giant leap. What's our next giant? What's here? What do you think our next giant leap is? Transformational. We've done it already. Where do we go next? Because I don't see anybody else. They're all following. What do we do?
Sure, I saw hands.
I mean, I can't answer that question. Yeah, and I guess my comment, and it's to sort of bring it back to what Sylvain was saying, is I understand not sort of making it a requirement to have PFDs involved, but what is it going to take for researchers and clinicians to understand that that is the only way to understand what they're trying to study? Right? So I think that is the big question. So I don't think forcing them, yes, makes sense, but there has to be, like, you know, so many of us, and I can only speak as a clinician and a researcher, and having patients that I can empathize with and speak to and build relationships with, that is not enough, right? I think what's important is to have the patients be involved in this. So whether it's CIHR or CDTRP or et cetera, what do we need to do to have that happen?
Thanks, coming.
I'm going to speak on behalf of a patient partner perspective. So one of the things that I think is missing from this list, and I know many patient partners feel this way, but when you walk into a study, you want to feel that you are the expert, that you're a credible place at the table. And so I often use CDTRP as a brag book to other organizations. And I know Stephanie knows that because I was just at a conference with her. But the one thing that I think is missing, because I've looked in literature to find this, is that prove that patient partners are important to have at the table. So as I come to the table, I also feel like I have to prove that I'm important to be there. I have to bring my best. I have to bring something different that's already not being offered. So the question is, at the research level, how can we measure the impact patients make on that research study? Is it defining the question? Is it providing, background? And how do we measure that so that we can also prove that patient partners are valid and credible sources to be at the table in research? And like I said, I've looked in research and I actually had a conversation recently with the professor that I was talking about this, working in patient oriented care research. And he agreed there's not a lot of good data collected on the value that patient partners bring to a research study. And we all know that this is important because we're all sitting here talking about it, but it's just something that's lacking.
Thank you. And if I can add something, it's not very much about the how. It's about the what and the willingness, so back to Sylvain, of keeping track of those things. So when you're in your study and you're actually working on that question with patient partners, keep track of what changed. What is the angle that actually, shifted because of that voice around that table?
Hi. Manuel was talking about research paper being submitted with co-applicants being a patient. And Sylvain was talking about willingness. I'm kind of a dreamer. So if we could think outside of the box and move one step further, maybe we could have research submitted by patients, families, and donors, supported and coached by researchers. I'm not saying I'm a researcher and I can know how to do your job, but if some research could be driven by patients, donors, and families, I think we would move a step further. Thank you.
So following up on that last comment that was in terms of what was measured. I think it is important for the patient and family donor partners to keep track of what was changed. The problem, though, as a scientific question, is how do we know that changes for the better? Now, I've drank the Kool-Aid. I think this is great. I want to have patient partners. But if we're talking about there's no alternate history where there weren't patient partners involved, and there's no comparison. And so I don't know as a scientific question how we produce exactly that data you're talking about that really shows, because in some ways it's a self-evident answer. It's yes, these are the people who are going to be affected by this research question. We need to ask them what outcomes are important. Therefore, we incorporate those outcomes into our study. That it seems so obvious, but I don't know how to study it in a way to convince people who do not already believe that in the way that I do. I believe it. I just don't know how I would convince a doubt with that.
Can I? I'm going to jump in over here.
Yeah.
And I think this is an important follow-up in terms of issues of methodologies, because I think that a couple of things, but from the scientific side of things, the how you do things matters. And I think that how has to change. Like if we're thinking about what is the leading edge might be bringing more things like citizen science practices into things like epidemiology and healthcare. Oh, let me see. And so, I think the to actually have where partners are not just weighing in on the question, but are actually deeply part of the methodology. I think that is actually what would be like the next push, right? That it's not just sort of like weighing in maybe beforehand, which is still novel, unfortunately, not just on the knowledge translation end, but actually deeply part of methodologies. And outside of healthcare, there's lots of it. It's just that it's not in healthcare at this point, and that I think is part what needs to change.
I just have a comment. I've been hearing what you guys are saying, and sorry, I apologize. So we all know the value that patients bring to research. They expand our views, because we're always like targeted into one thing, and then you guys come in and bring another perspective, and then we're like, oh, we weren't thinking about that. So that is great. But if we start thinking on the knowledge to action framework the CIHR puts for us, maybe that's the way for us to try and evaluate the impact of having patient partners in research, right? Because we could maybe compare a research that has no patient partners in and how they were able to actually use their results into practice, whereas in another program or another group that has a patient partner, and how effective they were to actually have their results implemented into practice. So I think the focus should change, not to the middle part or the process part of research, but the end goal, which is the beneficial part that I see as having your voices valued and heard, and input into the research that brings actual change to practice.
Anyone else? Then Mike.
Measuring. I remember measuring success. Talking about CIHR, I remember I didn't count it, but being a co-partner in a project as a grant proposal, I was at something like 40–60% of getting the money all the time. So getting the grant. This is also like going like, yeah, I think I got a good score. And I think I was maybe more at the 60–70 than that. So having something that is pertinent and the real plan, not a fake plan like I've seen so many times. There's lots of things like that. I don't think we have to put patient partner everywhere. Like we don't need to put a biostatistician on every project or a pathologist or something like that. There's moments, and it's okay not to have patients at some point. Don't tell anyone I've said that. I don't work for COPPP anymore. But I'm just saying, but I think this is also, and it's not rocket science, but it brings back to why and not changing everything. Yeah, and baby step.
Second.
Right there. Perfect. Go ahead, Linda.
A great presentation. There's different perspectives too that a patient, family, donor, partner brings to. Hold it closer. So we're bringing our patient, family, donor perspective to the table, but we're also bringing other experience and professional skill sets. And so how does the impact of that professional skill set that comes to the table also measured in terms of impact? It may be economics, it may be financial, maybe epidemiology, it may be a medical background, but that perspective is coming with the personal experience that the person has. And it would be difficult, I think, tricky to try and measure the impact of each and separate that out.
I just want to move on to making you reflect on the next big thing, the next phase. What's next? Because there are a few things here that I'm hearing, and maybe an inch of an answer I can give you is that patient engagement is inherently a social intervention. It cannot be isolated from any of the other dynamics you are living in the CDTRP. And I'm gonna step up. One thing we know from a comparative study that we did with 5 networks, including CDTRP, one results that will be transferred to you very soon from the study we did with Davina Banner-Ducaris. One thing that came out is that there is a direct relationship between patient engagement activities and funding cycles. I don't see any of you, falling off your chairs. But it is a big result. Why? Because the first thing that is impacted negatively by uncertainty in funding of a research network, it's patient engagement activities. And that's huge because it means that if we are not securing funding or a minimum core funding for networks, there will be fallouts in patient partnership. And in that, there will be losses in relationships and probably lower impact of that partnership aspects in the research. So this is one thing that comes out from, one method, that is the comparative method of using many of you organization and comparing your activities. And there are other ways. I'm in that type of research business, but we need to really think about patient engagement a bit differently. It's not an intervention, it's a social one. It is not one thing that can be isolated from the rest. It is not just there for better research. It is also there to change the way you work, change the way you think, have a different voice around a table. Might not always be for the good, but it's not always for the good when we have our colleagues around. Some biostatisticians might be really good, but they're not necessarily leading our research to the right next phase. So this is a question we're not necessarily asking when we think about other researchers, but we do with patient partners for a bit an rather interesting reason. I want to move on to the second set of questions, because I think it actually brings us to think about what are your priorities next and what do you want this to become? Because, we are at this stage. There's another thing that we've learned from that comparison of research networks is that there are phases to creating that partnership, sustaining it over time. And that sustainability, moment is all about improvement, but also prioritizing what's next for you. And I think that's what actually Sunny was actually driving us towards. What is important for you specifically at this moment from your experience as researchers, trainees, patient partners? Sylvain was pretty loud about his priority next and what he thinks we should do. But should be, what's for next year? What's for the next 5 years? And how should we mobilize you individually and collectively in the next phase as a committee, but also in a project? I'm hearing about projects maybe driven by patient partners. That's one interesting idea. Do you have any others? Again, taking my mask back on. Any ideas? There's the Mentimeter, and we're going to also use the 5 next minutes to gather your thoughts. I see Marie-Chantal, I'm going to come to you.
Thank you, Audrey, for all this work. This is very interesting. And it's funny also just to see the evolution when we start. I remember some of the researchers were reluctant to, it's not everyone who drank first the Kool-Aid, as Matt said, but now, it's taken for granted in the CDTRP to have patient, family, and donors partners. However, I think, one of the risks is to take it for granted and not, continue to mobilize everyone and to continue to pursue these important relationships. And I think, I think one thing that we should, maybe the future of patient, donor, and family partnership would be also to have,
patients who are training other patients and patient mentorship in research. And so maybe that's the future. So, yeah.
Thank you, Marisol. Holly?
So this is my first time at a CDTRP conference, and so I'm seeing all of the work that's been done in this area, and it's really quite amazing. I was just thinking as this was going on, like, what if we created some sort of registry? You have a systematic review, you register it in Prospero. What if investigators could register their trial in a patient-oriented research, and then you could track the output voluntary? I don't know, random idea.
Yeah, that's a good, like, crowdsource your the impact and then get that information flowing. That's a good idea. That could be in the portal, Manuel. Go ahead, Sandra. You have a mic already.
The things that were said that were great. And I'd love to be able to reply to all of them, but we don't have time for that. But one of the things I wanted to do in what's important to me is that one of the things that we did do in 2015 is we set, and this is a work that Marie Chantal led, was we set a list up of what patients considered priorities, patient family donors, and what researchers and clinicians did. And I often go back to that sheet. I think there's 14 or 15 items on there. And being, I assumed most of you knew who I was. I didn't realize we were supposed to introduce ourselves, but I'm the co-lead for Theme 5, Sandra Holdsworth, liver recipient of 27 years. And so one of the things as being the Theme 5 co-lead is I go in there and say, well, there was quite a few things that fell under our theme. And I'm like, what have we covered, right? And so I really think that it was interesting what Sylvia said, because although I've been doing this work for a long time, for the last 5 years, I've been doing a lot of work in health systems transformation in Ontario. And there was actually one of the patient partners I work with, he says, what if all the funding went to the patients and then we determined what was going to be a priority? And so for Sylvia to say that in research, like, wow, we're rebels here, aren't we? But I don't think that's necessary, but I think we go back to what are the priorities and what do patients want to have research done? And, you know, I do see Tanya there, and I used to say to her and Sunita, I said, we already know what the answers are to these research questions. We need it. So for example, when we did all this work on, is it important to have information on exercise, nutrition, and mental health? Mostly it was exercise on this one for patients beforehand and after. Well, yeah, everyone should have that. Let's get it done. Well, we're going to do this research, right? And so, like, you know, a lot of the things that we do research on is that patients go, yep, that's good. Let's get it into clinic, right? So, and I also like to go back to, like, one of the things that was said, like, yeah, we do bring all other skills with us, but I also want people to value that a lived patient experience is a skill. You know, I jokingly said that, you know, I have a master's in navigating our healthcare system. And one of the gentlemen that was a professor, he said, oh, Sandra, I think you have a PhD. And I thought that was funny, but we do bring a lot of experience. But I also want people to realize that there's a lot more things in research that we could be involved in. You know, a lot of times we get the grant and then we don't hear much back after that, but we should be there when the question's done. We should be there when the grant's being written. We should be looking at the different methods that are being approached. And I think what we can have an impact is, like, when you are engaging with patients, however you do that in the research that you do, we can give you clues and best ways to get the answers you're looking for, or how to recruit the right people and stuff. And we really can help with, like, you know, different parts of your research. We just need to know what's going on. We used to say that there's a, you know, there's a part that, okay, everything's good. And then it feels like, okay, they all disappeared on me. Where'd they go? And they come back and it's like, okay, we're ready to do it. And I'm like, remember asking the question and went, well, what did you do? Well, we did a system analysis. And I said, well, what's that? And I said, well, we could have helped with that. So now, you know, our researchers are doing that with us. And then the other thing I wanted just to quickly bring up as well is that when I talked about community, I think that we also need to bring in community into our conversations. I think it's a really like untapped resource. If we have the general public and organizations that have nothing to do with transplant that find out what we're doing, that might be a good source to get funding. They might find it interesting and things like that. And they think, oh, that's a good group to fund. So.
Thank you for that, Sandra. Do you want to go on, Mariam? Yeah, we still have a few minutes.
Take advantage of every minute.
Yeah.
Yeah, no, again, thanks everyone for your thoughts and feedback. We're collecting all this information. So it'll help us go into next steps. A couple of things I suppose I want to address. You know, earlier we asked, who do we have to tell? You know, who should be informed of what we're doing? And I said everyone, and I still stick by that. Mostly, I'm looking at the mentee here,
Yeah.
and a lot of the questions and comments that are being, you know, put on mentee, we have answers to.
Yeah.
A lot of the suggestions of the work that we should be doing, we are doing, or we're continually developing. So I think that's something that I look at you, Patricia, but you know, CDTRP, you know, that's something that we have to do better. To your comment, Sandra, about, you know, involving community and to what I said earlier about really diversifying our perspectives and diversifying who is involved in CDTRP. You know, I struggle with that one, not in the sense that I shouldn't be happening. Of course it should be happening, but my worry as a platform manager is onboarding PFD partners and then not having a role for them, right? So when we talk about disengagement, I know when I'm a patient partner, if I get involved and I don't hear back or there's no opportunities to give back, I'm not going to be involved with that organization. So this is where I look at the researchers and our trainees, and you know, you have to have that lens. Like it has to be a core piece of your work, because I don't come up with the research projects. I don't, you know, I'm here to support. And if we don't have researchers who are actively wanting to put to integrate PFD partners in there, then we're going to lose that fundamental piece. And I say that I also struggle with, like Matt, you said, you know, you've drank the Kool-Aid, and that's fantastic. You know, part of me, as you said that, I was like, well, do we need researchers to drink the Kool-Aid, so to speak? I'm not sure how I feel about this, so I'm just gonna talk in the sense that, one, of course, we want them to be enthusiastic, and we want them to integrate patient partners. But at the same time, you know, this should just be a core component of all research. You know, with CDTRP, you know, our PFD partners are part of the Innovation Grant Peer Review. I know CIHR has implemented something similar, as are other organizations. You know, when you develop your grant applications, for example, knowledge mobilization plans are there. Like, that's just something you have to do. So my thought is, you know, do we want them to drink the Kool-Aid? You know, if we continue to establish and continuously improve our platform, you know, does that enthusiasm have to be there, or do they come to us and say, you know, we're here to support you, you know, we're here, and this is how you can integrate patient partners to this. So I'm of mixed feelings on that piece. So maybe I'll just stop speaking, but curious to know what others think, and maybe Key, you have something to add to that.
I guess I had the last few seconds. So just to kind of wrap up and touch base, coming from a trainee perspective, I see another area of patient family donor that can also be involved in is just kind of like giving students the perspective, right? As an undergrad, as a high schoolers, we see what I consider the showy piece of science, you know, the volcanoes, the cancer, the on every billboard, the prostate cancer with the lemon. We see all of these as undergrads, as students at the very, very early segment of our careers, but we don't really understand what's transplant. What is transplant? Like, if you go out on the street and have a conversation with a random student, random person, there's that level of understanding and that level of comfort is not there. The idea of taking an organ and giving to someone else and still having it work is very novel to a lot of people. And some of these technologies that are being developed to keep these organs and keep making transplant a feasible possibility over long distances, over different provinces or even countries, right? Over different blood types. That immunology component, that biological component is not really communicated. And I find coming from as a student, sometimes like you're very, very nitty gritty in your research. You're like, why is my cell line not working? Why is the cell culture not working? What is the p-value of this bunch of stats? But you're not stepping back and seeing the bigger picture of why are you doing this research and what is the impact? Because the impact might be there when you're writing the grant and proposal, but from that point to the final point of a 3-year, 4-year research experiment, especially when it comes to wet lab, that's a long point and long time to keep that motivation going. And especially for most of our students, we're always thinking about how to get a better grade, how to please our professors. We don't see, or we're not always reminded or reflective of the fact that our work actually has real world impact. And I think that is also another area that requires collaboration between PFDs as well as trainees. And I kind of want to open maybe we can talk about this later, of how we can bridge that gap between trainees and PFDs, plant the seeds early.
That's important. I want to use the last minute and actually help you understand why we went for a presentation or conversation today instead of a presentation that took the whole hour and a half. It's not just the idea of having you involved in this work, but also because this work is about involvement, but should actually involve you. And that's why the last question is about how you would want to be involved in this evaluation work. Because I really think, and I think it's a shared understanding that if we do evaluate patient engagement, it needs to be in partnership with all of you. And I'm not talking just about, patient, family, donors, but I'm talking about researchers as well. And by the way, my own barrier to my own research is usually your perspective, you researchers, in evaluating patient engagement. Why? Because usually you see it as an interest for your PFDs, your partners, but not necessarily putting your voice in. And I think that your voice is very important. Why? Because your perspective on what it transforms in your work is, paramount to this work, but also because we want reciprocity. Where patient partners see value, we want to see you have also value. That reciprocity in the data, in what we collect, but also in how this information is going to speak to you and put your research in value is really important. And thank you for participating today, because this is not just for show, it's also for use. And I love what Manuel just said. There are tons of things that already are collected, tracked, and actually maybe are not so well communicated. Next step and next priority might be just to communicate that better to you. So that's great. It's not a big thing. It's a thing, but it's not a big thing, and it's an improvement that can actually be done really quickly. I also want to, talk about next steps, because there is one other challenge that was mentioned underneath all of your comments, is to actually track it, do it like rigorously, have that data collected, and being able to report back, but also maybe do research about what is going on within your network. And I think that this is what we are building today through that conversation, is your own collective capacity to actually talk about patient engagement, move, act, find your own strategies to improve, but also, maybe publish on what was done and what will be done at CDTRP, because that's also part of being a researcher and being part of a research network. So next step is to also, create that dashboard, create the capacities. It might be tools, it might be communication ways. We're going to think about that, but we want to thank you collectively for embarking in this conversation. Thank you for Sandra, Key, and Manuel for, keeping up with me and helping me out. And thank you to you all, and have a great rest of the conference.